Well, first of all, thank you very much for that very kind introduction. And Dr. Greenberg, I'm really delighted to be here at what I really consider to be a very important meeting. I love being able to leave the nest, so to speak, and get out and talk to people who are really providing care at all different levels related to newborn screening. So here I am, and I'm just really delighted to be able to talk about this topic. So the topic that I was assigned, as you can see, is 50 years of newborn screening. How do we get here? And I'm not a medical historian. I'm going to put things through my own lens and sort of talk about where I think things have been and how that impacts on where we're going. And certainly I'm going to give a preview of some of the stuff that Dr. Powell will be talking later today about in terms of looking at the future, as well as Dr. McCullough, and ethical issues. I think the group is small enough that as I go through, if I say something that doesn't make sense or you need clarification, just go crazy so that I can see you, and then hopefully we'll have time at the end to answer questions. And I'm going to do probably the most important thing, which is to take off my watch so I can look down and keep us on time. So there we go. So let's get into our Wayback Machine. And in 1957, this is a picture of Dr. Bob Guthrie, who first developed a method to monitor phenylalanine levels in blood on filter paper. And when this was initially designed or developed, it wasn't as a method for newborn screening, but it was a way simply to assess phenylalanine levels in individuals who were known to have PKU. The test itself is a bacterial inhibition test. I guess I should ask, how many people here consider themselves to be laboratory experts? All right, I don't see a lot of hands, so if I mistake something, that means that I'm not going to get in trouble. Again, I'm a primary care provider, but it's reassuring to me not to see a lot of hands go up. So the idea with the bacterial inhibition test was that there was somehow, through the modern miracle of technology, there was a media that would not allow bacteria to grow unless there were high concentrations of phenylalanine. So if there was a lot of phenylalanine, for example, what you would find in the blood of somebody with PKU, the bacteria could grow, and you could look at the amount of bacteria on these filter spots to identify those individuals who had high phenylalanine levels. So again, in 1957, it was developed as a way to monitor individuals with phenylalanine, but not to identify PKU. And of course, in the intervening time, there was a lot of excitement and interest in the ability to identify early children with PKU, because then you could institute a diet to lower phenylalanine levels and help protect their brain development. And so all this began in 1961 in two hospitals in New York with funding that was initially received from the Children's Bureau, which was the predecessor of the Maternal and Child Health Bureau, which is a federal organization I'll be talking about later. And from there, things went into a national trial. And by 1967, there were 30 states who were mandated to have newborn screening for PKU. It's interesting, as I was looking this stuff up, I was born in 1967, but I haven't figured out yet whether or not I was screened. So I hope that gives you an idea of sort of where the dried blood spot came from. And what's particularly interesting is that the dried blood spot has really stayed central to the work of newborn screening. And of course, we don't use the bacterial inhibition test anymore. Most of the tests, not all the tests, but most of the tests that are done are with tandem mass spectrometry. And I have a picture that I found of what that device looks like. But really, to me, one of the miracles of the dry blood spot is its central ability to link what happens in the newborn nursery to public health agencies, because public health laboratories are running the spots and they get the spots sent from where the child is born. It really creates this nice, tight integration. So although the technology has moved past where the bacterial inhibition test, I think that it's really interesting how the blood spot itself has served as this great linkage. So now we're going to have one slide where I'm going to talk about 2 decades. Over the past couple of decades, there's been a rapid expansion of conditions that can be detected A lot of that is driven by new screening technology. We talked about tandem mass spec a second ago. But related to that, there are also new treatments that have developed that have pushed where newborn screening is going. And I'm going to dive in and talk about that in a little bit. Newborn screening, as you all know, is primarily a state function. So individual states determine what is on the panel of newborn screening tests. So historically, there was, as newborn screening programs grew up, there was a lot of difference from state to state. So there's been a lot of work in the past couple of decades to harmonize those conditions across states. Again, we're going to be talking about this in a little bit. There's been better coordination within and across public health agencies and healthcare providers for both short and long-term follow-up. I'm going to define those in a minute. And I think one of the unique challenges that have come up more recently related to newborn screening is the emergence of point-of-care testing. So this is testing that occurs for the baby in the newborn nursery, where the results are available to the care providers there, which delinks screening from what happens in the public health laboratory. So the two examples that I put up here are screening for congenital hearing loss and the newer kid on the block, screening for critical congenital heart disease. I think this presents a unique challenge for how newborn screening programs are going to operate now and into the future, because looking into my crystal ball, I think that there are going to be more and more point-of-care newborn screening tests. So let's think about where newborn screening program is now. So it's the largest coordinated genetic screening program in the United States. And I think we can easily make the argument that it's probably been one of the most effective public health programs that occurs across the United States. Again, individual states figure out what things they're going to screen for and how the screening programs operate, but there is some input from federal agencies. I'm going to show how that works, at least my understanding of it. But there are a lot of challenges related to newborn screening. So what things should be included in testing? How do we screen for it, right? So there's different screening methods even for those conditions that we might all agree ought to be on screening panels. What about short-term follow-up? So now I'll talk about short-term follow-up a bit. When I think about short-term follow-up, I think about all the things that happen from the time of screening to the time that the diagnostic process is done. So finding out who has a positive screen, tracking down those individuals with a positive screen, and then either ruling out or ruling in whatever the diagnosis is. Long-term follow-up is everything that happens from the time the diagnostic confirmation is completed through the life of that individual. And of course, as a screening program, it's that long-term follow-up that's the secret sauce, right? Individuals aren't going to benefit if they don't get the treatment for the condition that you're diagnosing. There's a lot of talk about DNA testing, and of course you can't see it now, but even the logo for this meeting, right, was a double helix. So I think it's important to step back and think about how DNA testing and genetic testing more generally is related to newborn screening. So most of the conditions that are included in newborn screening are heritable, right? There's some conditions that aren't heritable, but are present in the newborn. So, for example, congenital hypothyroidism. Testing for newborn screening, however, currently, as of 2014, is not primarily DNA-based. As I think Dr. Powell will be talking about later, that's likely to change in the future. But most screening right now is based on looking at, for example, metabolic products. So if you have a blockway in some metabolic pathway, you get lots of backup products before that, before wherever that blockage is. And so you can pick that up with technology like tandem mass spec. There's sickle cell disease, and there's different ways of identifying babies with sickle cell disease, but it's not primarily genetic now. There's cystic fibrosis screening, which can be a DNA test, but there are also other markers. I have IRT, which is immune-reactive trypsinogen, as a way to screen for cystic fibrosis, because many newborns with cystic fibrosis will have elevation of that. There's severe combined immunodeficiency, the bubble boy disease. So that is a genetic screen, and that you're looking for these little circles of DNA in the in the white blood cells or red blood, where you screen for, yeah, exactly. So I'm looking at my expert. Again, I'm a primary care physician, so I rely on people who are actually geneticists when I get in trouble. But you can look for these little loops. So, it's a DNA test in that you're looking for these loops of DNA, but you're not sequencing. Congenital hypothyroidism, it's an example where you're looking for elevations in specific hormones. Hearing loss, which is a functional screen. And then critical congenital heart disease, which looks at levels of oxygen in the blood as an indirect marker for what might happen with babies who have critical congenital heart disease. So, the question comes up in 2014, why don't we have more direct DNA tests? And I put this picture of a clock right up there because I think it's only a matter of time. But for the purposes of my talk, the thing that I want you to remember is that there are many, many, many mutations that can occur within any particular gene that you might be looking at. And oftentimes, the significance of any particular mutation is unknown. It's oftentimes difficult to predict genotype-phenotype correlation, so that you might be able to predict, for example, that an individual baby is going to have something like Pompe disease or Krabbe disease, but it's hard to know, well, exactly when are they going to get into trouble? How severe is this going to be? There's certainly cost issues with doing DNA sequencing. It's 100% true that the cost every day is falling, but there's to do the DNA sequencing, but there's a lot more to these costs than just the laboratory costs. It's really a paradigm shift, right? So most newborn screening is based, historically has been based on looking at metabolic products that shouldn't be here. Now we're trying to find the particular cause of the problem in the first place. And then there are about 10 million other concerns related to this genomic sequencing, which I hope we'll have a chance to discuss, and I know you're going to hear a lot more of as the day progresses. All right, so that's sort of where we are in newborn screening, but newborn screening is a program, right? It's not just the screening test, but it's the whole everything, all the follow-up that happens. So I mentioned before that I really consider myself to be a primary care provider, and I just want to put the perspective of the things that we're talking about into the characteristics of pediatric care. So how many people here are primary care providers of some type? Okay, and how many of the people who are primary care providers of some type are pediatricians? And then do we have any family docs here? Okay, great. So that's very helpful because I want to make sure that I tailor my comments to you all. So pediatric care, and I'm in here, I'm talking about all child health care, not just the care provided by pediatricians, is really focused on preventive care. We certainly take care of acute illnesses, but the great thing about being a pediatrician, fortunately, is that most acute illnesses are self-limited. But really the bulk of other care is related to taking care of common chronic illnesses. So asthma, I put down a list of the so-called new morbidities, things that child health care providers are having to deal with more and more: obesity, mental health issues, and substance abuse. And then there's this category of rare chronic illness. And the thing about, especially if you go into primary care practices, there may only be one child with PKU that comes into the practice every few years, or maybe depending upon, if you're a family doc, it may just happen once in your whole career. We're talking about a condition that affects maybe 1 in 10, 1 in 20,000 individuals. But if you aggregate all the rare chronic diseases that we take care of, then it starts to get big, and it makes you think we really have to have systems in place to be able to manage these children in a safe and effective way. So if you look across the whole population of children, about 14% of children have special health care needs. So if you sort of look at the population of children in the United States in a non-categorical sort of way, there are 14% of children that have special health care needs of some kind. And it's important to remember that most of these children are taken care of by a generalist. There just simply aren't the specialists out there. And there's a renewed focus on the medical home, that is being able to provide comprehensive, coordinated care for the individual and the individual's family. And for the longest time, I would come and talk to people or give talks about the medical home, and I would be like, well, I think this is aspirational, and I don't know how much this is really actually happening. But I think that there's a lot of optimism about the degree to which medical homes can be better for children, in part because of new reimbursement strategies that are coming down and the expectation for disease management, as well as electronic health records, which, right now, electronic health records have a lot of problems, right? So interoperability, the degree to which you can really pull out the information that you want. But I think that we're really on the cusp of being able to do great things in terms of population management for children with rare disease through electronic health records. So, maybe that's sort of my aspirational moment right now with where I hope things go. But I do think that these well-coordinated, well-designed electronic health records are going to be sort of the lifeblood of our health system. All right, so with that in mind, and again, we're going to revisit this again, I'd like to talk about the traditional screening criteria. So this is a distillation of work that was funded by the World Health Organization in the 1950s and then in the 1960s, the so-called Wilson and Youngner criteria. Have people seen these before? Yes, yeah? All right, who has never seen these kinds of things before? Because that'll help me figure out how to, and who has? Okay. And who's checking their email? Okay, so which would be fine, because I would probably do that myself periodically. So the idea with screening, again, is with screening, you're screening for particular conditions. You want to identify things conceptually that if you found them earlier, you could get better outcomes for early detection. And so if you think about this, you only want to screen for things that are important health problems, right? So an important health problem could be something that's common, that affects a lot of people, that maybe doesn't cause a lot of morbidity or mortality, or it could be something that's rare but catastrophic. So when somebody says something's an important health problem, don't just get fooled by the prevalence of the condition, but think about the impact of the condition on society at large. The natural history of the condition should be understood, right? So if you don't know about the natural history of the condition, you can never evaluate whether or not early detection makes a difference. Now, I hate this term natural history, because there's nothing natural about any of the conditions that we identify, right? Because as soon as we find them, we start doing things. So, but that's sort of the term we're stuck with. There has to be a latent or early symptomatic stage. That is, if you go from having a condition to being really symptomatic all at once, then there's no need to screen, because you'll identify this person as having a problem. There has to be a period where, where it's not clear that the individual has some condition. There has to be a screening test that's available, that has to be easy to do, acceptable to the public, accurate. We can argue about what accurate means, and reliable. There has to be treatment, and the key thing about the treatment is that early intervention has to lead to better outcomes. And diagnosis and treatment must be cost-effective. And we can argue later about what cost-effective really means. I will say that I talk to a lot of people sort of in the health policy realm who think about cost-effective as being the same as cost savings. There are very few interventions that are actually cost-saving. Normally you have to, pony up something to be able to get benefit back. As a matter of fact, I was thinking this morning about, what things really are cost-effective in terms of pediatric management. And the only thing that could come to my mind immediately were seatbelts. So it's really hard to come up with things that are cost savings, but there are a lot of things that are cost-effective where the value that you get for the money that you put in is really worth it. So that's all fine and well, but newborn screening raises 10 million problems that just don't fall neatly into these criteria. So what if screening might be benefit to the family, but not necessarily to the child, right? So imagine a disease like Duchenne muscular dystrophy, right, where there are questions about whether or not early diagnosis might help the child, but for the family, you might help them make informed decision-making about future children. What if screening might not benefit the individual until much later in life? So one of the challenges with screening for Pompe disease, which is a rare inheritable condition, is that it'll pick up some individuals who may not have problems until their second or third decade of life. And what do you do for them in the meantime, and how do you decide when to begin therapy? What if we don't know the natural history, right? So a lot of the rare conditions that we talk about in newborn screening, we don't really understand the natural history until we can start screening for it and identify children so that we can find out what happens to them. What if there's no treatment, right? So normally when we think about treatment, we think about things that we can do for the child to affect their, detect his or her morbidity or mortality. But what about, treatment that extends to the family? What does really no treatment mean? What's the role of public health, right? So there's no question that public health is under a lot of pressure to do more and more with fewer and fewer resources. So in some states, public health departments are required simply to, and I'd say simply, I know this is very difficult, but to do short-term follow-up and make sure that those children who had an abnormal newborn screen get diagnostic follow-up and then get plugged into services. But in other states, there's the expectation that states really be involved in making sure that they get treatment at least through childhood. Another challenge is the screening the function of a test or the condition. So typically we talk about we want to screen for a condition. We want to identify babies who have sickle cell disease, for example. But once you put in a screening test, you start to identify a bunch of other stuff. And to what degree do you let the technology drive things, and do you sort of report out everything you find? Again, I know these are going to be topics for later today. And then something that historically has affected newborn screening is figuring out what defines a target, what's the case definition of a particular condition or a disease, and what defines the kind of outcomes that we're looking at. And it becomes really important when you want to understand the epidemiology and also to understand whether or not you're making a difference. Because even things that we screened for a long time, like PKU, it turns out, there's kind of the classical PKU that everyone thinks of, and then there's these variants where individuals may be more or less severely affected, and where the treatment may not just be diet, but new medications that are evolving. And so, it's very difficult not to let the technology sort of drive where things are going and sort of be in front of it. And the other thing is that there are these so-called secondary conditions, things that you might identify in the process of screening. So, for example, when you screen for sickle cell disease, you may find a bunch of other hemoglobinopathies, some of which may benefit from early intervention, and some of them, who knows, and what do you do with that information? So there are a lot of questions out there, okay? The other issue, and I know this has been something that's been an issue in Texas, is the use of the dry blood spots, right? The dry blood spots that are collected are an incredible resource, right? So state health newborn screening programs can use these for quality improvement, quality assurance. They can, if somebody is a false negative, they can go back and find the dry blood spot. But they can also just run tests on them to make sure that things are working the way they want. So from that perspective, it's a really valuable product. These dry blood spots can also be used in the development of new screening tests and new screening approaches. So there's many examples of laboratories getting anonymized dry blood spots and using them to develop new laboratory methods. They can be used for surveillance purposes. If you want to find out what's going on with the epidemiology of a particular condition, you can go back and look at the dry blood spots. Certainly, they've been used for forensic purposes, including in the unfortunate event of an unexpected childhood death. And then there's lots of other biomedical research that can go on, either related to newborn screening or outside of newborn screening. So I put my little hot button down there because this is a hot button issue. I don't know what the answer to the right way to use all this stuff is, but certainly there's been a lot of talk, and I know there's been a lot of talk here in Texas. It's not an area that I'm an expert in, but I just want to lay it out on the table so that if people want to talk about it later, there's the opportunity to do so. All right, so now let's go and talk about what's going on. Remember at the federal level, so I said that newborn screening is fundamentally a state thing, right? So, remember your Constitution, anything that's not explicitly outlined as a federal role falls to the states. Well, that's why, the way I think of it, that's why newborn screening is a state function. But the feds are very interested in this because they want to make sure that no matter where you're born, you have access to those screening tests that are known to lead to better outcomes. So I put down, I just tried to think of like all the acronyms that I hear all the time, and thought that we could just talk through them because they do really play a very important role. So the first one up is HRSA, that's the Health Resources and Services Administration, which is like a sister agency of the NIH. It's within the Department of Health and Human Services. They provide the block grants to states that operate a lot of newborn screening programs and run programs like Medicaid. And they also closely coordinate with a federal advisory committee that makes recommendations around newborn screening. There's the NIH, the National Institutes of Health, which fund a lot of the work that leads to the development of new screening tests, novel ways to detect things, as well as treatments. There's the CDC, the Centers for Disease Control and Prevention, which is in Atlanta, which has done a lot of really important work around quality assurance across newborn screening labs. They also do a lot of work around looking at the epidemiology of birth defects through something called the National Center for Birth Defects and Developmental Delay. There's AHRQ, which is the Agency for Healthcare Research and Quality, and they are very interested in things like comparative effectiveness and figuring out how do you put systems of care into place so that once you identify somebody through screening that they have good outcomes. Okay, so are people pretty much aware of these federal agencies, or is this new information? All right, who thinks it's new? Some people. Okay, I'll keep going. There's this thing called it used to be called, and I used to jokingly try to do it on one breath, but I don't think I can do it anymore, the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children, the SACHDNC, which is now the Secretary's Discretionary Advisory Committee on Heritable Disorders in Newborns and Children. So there was something called the Newborn Screening Saves Lives Act that really helped establish in law the work of this advisory committee. This advisory committee makes all sorts of recommendations around newborn screening, which I'm going to go over in more depth in a second. The Newborn Screening Saves Lives Act sunsetted, and because of that, the advisory committee might have actually disappeared. But the Secretary of Health and Human Services, back when Secretary Sebelius was still the secretary, opted to form a discretionary advisory committee. So the funds that keep this advisory committee afloat are from the Secretary's discretionary funds. I don't know how much there is there, but I don't think a lot. But the new version of the Newborn Screening Saves Lives Act is like working its way through the halls of Congress. It was recently approved by the Senate, and then went over to the House, and they approved it with some minor amendments, and now it's back on the Senate side. And of course, now we're in August recess, so I have no idea when this is going to finally come out. Now, there's two things I want to make sure that you know about. There's the National Coordinating Center and it's got like a long, complicated name too, but it's like around newborn screening. That's run by the American College of Medical Genetics, and then these regional coordinating centers. So I've highlighted the different regional coordinating centers that you can see they're color-coded. I'm from the Southeast region. The whole idea of these regional coordinating centers is that folk get together and think about how to improve the process of newborn screening, and then through the work of the National Coordinating Center, they share their findings. It's actually a very rich and active group of centers. And if you're really interested in becoming part of newborn screening outside of just Texas, then partnering with your regional coordinating center would be, I think, a nice beginning way to develop those sort of partnerships. There's something called New Steps, which is, again, funded by the Department of Health and Human Services, and that, again, is to try to improve the process of newborn screening. There's something called Baby's First Test, and if you're interested in information for families about newborn screening, that's what that was developed for. It's sort of a clearinghouse of information, and you can Google Baby's First Test and find it. And then finally, sort of the last acronym that I could think of was the Newborn Screening Translational Research Network. And so this was formed to do research around newborn screening tests, and they have virtual repositories of dry blood spots that you can get access to if you want to develop a new test. And my understanding is they're going to be working with hospitals all over the place to figure out how to implement and evaluate new screening tests. So that's all the federal activity I can think of. I'm sure there are many other ones, but the thing that I want to impress on everyone is that although there's a lot of work going on the state level, there's also this huge amount of activity going on at the federal level. But let's talk about the advisory committee. So the goal of the advisory committee, which is the Secretary's Discretionary Advisory Committee on Inheritable Disorders in Newborns and Children, one breath, is to provide advice and recommendations to the Secretary about the conditions that should be included in newborn screening. So again, the advisory committee doesn't say what should be included in newborn screening, but provides advice about that. It's really up to the Secretary, and if the Secretary endorses that something should be included in newborn screening, it becomes part of the RUSP. I mean, there are a lot of acronyms here. The RUSP is the Recommended Uniform Screening Panel. This is a list of conditions for which there's strong evidence that early detection makes a difference, and so these are things that newborn screening programs should look for adoption. And again, newborn screening programs are operated at the state level. Many of them follow the RUSP. I'm not aware of a single state that has any sort of legislation or rule or anything saying that they have to adopt the things that are on the RUSP, but the folk that run newborn screening programs really look to the RUSP for guidance, simply because there's so many things that can be included in newborn screening. So where did the RUSP come from? All this started in 2006 through a project of the American College of Medical Genetics, which recommended 29 core conditions that should be included on expert panels, but it should be based on expert panels. So expert panels recommended for the newborn screening panel. So I'm sorry, I used the word panel twice there. But basically, this was expert consensus primarily about what things ought to be included in newborn screening. So there was this huge amount of pressure in the early 2000s to figure out what things ought to be done, because with the adoption of tandem mass spec, it was really things were all over the place. I almost said it was like the Wild West, but I'm like in Texas. I'm not sure if I should say that or not. So there was this huge amount of pressure. So it was all done on expert opinion. Expert opinion is subject to all sorts of flaws, right? Because experts come in with particular sets of beliefs, right? That's why we like experts. But it's not the same level of rigor that can be applied by other methods, and I'm going to talk about that in a second. But there was some criticism about how this core panel came about, and so the advisory committee has adopted a more evidence-based approach to doing this. And so, if I had a disclosure slide right now, I would put it up. My disclosure is that I oversee the evidence review process that the advisory committee now uses to make recommendations about what things ought to be included in newborn screening. So there's this evidence-based approach, and based on that, the recommendations were to add severe combined immunodeficiency screening for critical congenital heart disease or defects to newborn screening. And the advisory committee also recommended that Pompe disease, which is another rare condition, be added to newborn screening. It's been, I'm like looking around, about a year or so since the advisory committee voted to add that to the RUSP. The secretary, though, sort of up to her, when her decision about whether or not that'll be added to the RUSP comes out, and there's a lot of sort of deliberation that happens beyond just what the advisory committee does. And if that's something you want to talk about later, I can do so. The advisory committee, though, has also recommended against adding a number of different conditions to the screening panel. So the recommended uniform screening panel. This includes screening for hemoglobin H disease, which is kind of like a version of a thalassemia, Krabbe disease, which is a rare inheritable disorder, and neonatal hyperbilirubinemia. Neonatal hyperbilirubinemia is an interesting story because most babies will develop jaundice in the first days of life, and if the level of bilirubin gets too high, they can develop something called kernicterus, or another name for that is chronic bilirubin encephalopathy. If you have these elevated levels of bilirubin, if you catch it in time, there's treatment to lower it, and you can prevent the onset of kernicterus. And so it's definitely one of those cases where early detection leads to a better outcome. But in the review process, a number of interesting points came up. First of all, that clinicians are already doing a pretty good job of identifying babies who are at risk for kernicterus. And then the other important thing is it was unclear what this would mean for newborn screening programs, because babies who develop high levels of bilirubin need to get therapy very early in life, the first days of life, so that by the time health departments found out anything about it, the horse would be out of the barn. So this was an example really of an important screening test, but something that really best fits into the primary care model or the healthcare systems model, and not what happens in the public health arena. Does that make sense? Yeah, everyone with me? Good, good. So I want to talk a little bit about how conditions are evaluated. So right now, there's really three things that happen when a condition gets nominated. And anybody, I should say, anybody who thinks that there's a particular condition that ought to be in newborn screening, whatever that is, can nominate it to the advisory committee. If you find the advisory committee's website, there's like a 2-page form you can fill out. That then goes to the advisory committee, and the advisory committee evaluates those forms and decides whether or not there's sufficient evidence or sufficient likelihood that it could be added to newborn screening. And if so, then they hand it off to our group. They do that pre-evaluation phase before it gets to us, because developing these reports is so time intensive. So there are three things that happen. One is a systematic evidence review, so looking at all the published, and we also look for unpublished data about screening and treatment. So again, thinking about screening as the whole process. We look at the assessments of the bounds of benefits and harms. So the problem with studying rare diseases is that there are oftentimes few studies that are out there. It's just hard to assemble enough cases. But what you can do is you can look at best case scenarios and worst case scenarios and get a sense of how much benefit could come from screening from this and how much harm would be associated with screening for it. And we've developed a system based on mathematical models to do that. And then the third thing, and this is something that we're really focusing on now, and so there's some of you in this room we may even talk to about how to best do this, but it's evaluating the capability of states to implement comprehensive screening. This is a so-called public health system impact assessment. So it's not just good enough to know whether or not the screening test might decrease morbidity and mortality in childhood, but is this something that could even be done, and when could it be done? Because again, oftentimes you're talking about adopting a complicated new screening test. There may not be quality assurance methods in there. And then for those of you who are in public health, if all these demands are coming in about the kinds of things that you ought to be doing, there's an opportunity cost. So if you start screening for a new condition, does that mean there's all of a sudden some other important public health function that can't be done? And so our mandate really is to also look at these opportunity costs. So the advisory committee has a decision matrix, and I know there's nothing more than people like to do on Saturday mornings, look at a decision matrix, but I'm going to show it to you anyway. Because I think it's important that you understand how it is that decisions get made. And so there's really three things that the advisory committee looks at. First, it looks at net benefit, and you can think of net benefit intellectually as the kind of the difference between benefits and harms. There's no single metric for that, but it I feel like I'm going to walk over here, but then you'll lose me, so I can't do that. The advisory committee, and I'm not a voting member of the advisory committee. My job is just to provide the evidence reports to the advisory committee. The advisory committee first assesses whether or not there's a significant benefit from screening for this particular condition, or is there a zero to small net benefit, or is there even a negative benefit? A negative benefit you can think of as where the harms of screening might outweigh the benefits. And once it makes that decision, it also looks at sort of conceptually, how confident do we feel about this? Are we highly certain of it? Are we moderately certain of it? And you can see how that then puts you into different buckets. Next, the advisory committee looks at two things, and they're overlapping terms, and for that I apologize. It's a little confusing, but feasibility, you can think of it as, is this something that if a newborn screening program wanted to do, could they do it? Is the equipment out there? Have things been validated? Do we have ability to establish a diagnosis? Those kinds of things. And then the advisory committee looks at readiness. So if something's feasible, how long is it going to take you to do? What kind of things would you need to put in place to do it? So the advisory committee classifies feasibility into high or moderate feasibility and low feasibility. Again, these are gray terms, and there's no single metric for putting something into one of these buckets. And then readiness. And readiness is classified into ready. This is something that we could do in, I can't remember what the exact number is, but like a couple of years. Developmental, is it going to take longer than that? Or is just, there's no way that we could do this now, or most newborn screening programs just unprepared to do that. And once you do it, you can see how you end up with these different categories. And then based on the categories, recommendations can then go on to the secretary. So things that are the A's are things that looks like there's benefit of doing, but the implementation is not going to be easy. And those A recommendations then go on to the secretary as well as a narrative statement about what kind of issues need to be resolved for health departments to be able to implement it. Those things that are below the A, just the B, C, D's, and L's, are ones where the recommendation would be not to add it to the uniform screening panel. But the advantage here is that specific information can be provided by the advisory committee about what gaps need to be resolved. So, for example, we need to get better information on treatment, or we need to do a pilot study in a state to find out whether or not this is, even could be done under any circumstances, those kinds of things. And I can tell you that the funding agencies look at these things that are not A's to figure out what the major gaps are to help resolve it. So if you are an advocate for adding a particular condition onto newborn screening and it gets sent out for review and it doesn't, get recommended by the advisory committee to be added to newborn screening, that, doesn't mean that it's the end of the day, okay? The public health system impact assessment is something that again, we're really struggling with how best to collect this information. I will tell you that the expectation going forward is likely to be that from a time a condition is nominated to be added onto newborn screening to the time that a vote is made by the advisory committee is 9 months. It's kind of like having a baby. Okay, so there's really a lot of work that needs to be happened in a short period of time, and to understand across all states in the union what would be involved with adopting a test is daunting. So we did hold an expert panel back in April to identify the key topics that need to be considered, including organization and authorization of newborn screening programs, figure out about the screening methods, figuring out what needs to be done in terms of short-term follow-up and long-term follow-up. And without belaboring this point for this audience, know that it's really our goal to understand these issues, not from any particular vantage point, but across all states. And so we're, again, still trying to figure out the best way to do this, and we are going to be reaching out in the near future to get more advice. So let's talk about some specific issues in newborn screening, right? And so this is sometimes what I feel like my job is. I take the fun out of everything. So, I could talk forever about all the particular challenges, and you'll be happy to know that I'm not going to do that. But I do want to highlight some things. So, congenital hearing loss, let's talk about that. Widely adopted, right? This has been a great example of adoption of a point-of-care newborn screening test. The issue here is what happens in terms of follow-up. So, you read reports all the time that, there's, half the kids who have an abnormal newborn hearing screen never go on to get any follow-up care, right? How many people have seen those kinds of reports, right? Like everyone. Well, if you drill down into it, I don't think the story is quite that bad. A lot of it is these kids are getting evaluation, but it's just never getting reported to the right place. So I personally think that although it's suboptimal, there are some kids who slip through the cracks. I think there's a problem with lack of documentation more than the lack of follow-up care. I'm sure that there are regional variations in this like everything else. All right, let's talk about critical congenital heart disease. So how many of you work in a nursery that is screening babies for congenital heart disease? Okay, and how many of you are not to put you on the hot seat? Okay, I see a couple of brave people raise their hand, right? So this has been a great example of a screening test that really a lot of newborn nurseries are picking up because it's a good example of a clinical care service that can lead to better outcomes. Remember I talked about the bilirubin story before? I think a lot of people have made the argument that why is screening for heart disease, so you do this by pulse oximetry in the nursery, not the same as bilirubin screening? Why isn't this just a clinical service that babies ought to get? What's the role of public health? Well, the argument that was made about this, and I think there's a lot to be said for this, is first of all, it's a new clinical service that states aren't providing, and that it's complex, and newborn screening programs can play an important role in terms of helping nurseries adopt this, and also because many health departments do birth defect surveillance. It's the natural place to find out whether or not this intervention is making a difference. By embedding it into newborn screening, you're ideally getting rid of geographic disparities so that every baby gets screened for critical congenital heart disease. I will tell you that North Carolina just passed legislation to begin doing it, but about 2/3 of the hospitals are already doing it, and the ones that aren't doing it are the smaller hospitals that don't have access to pediatric echocardiography. But by mandating it, those little teeny hospitals are all of a sudden developing partnerships to do so. But again, I think that reasonable people can disagree whether or not this is an example of newborn screening or it should be just a clinical preventive service. So in terms of challenges that I'd like to bring out of these point-of-care testing services, I think figuring out when something belongs in public health and newborn screening versus clinical preventive service, I think is something that's going to become increasingly more important. Again, I think you'll understand that as Dr. Powell gives her talk later today. And then another challenge that we have is, what are the levers? What are the things that public health departments can do to support adoption and high quality care? Given that, while clinicians are also saying, why do we have to report this to public health departments? A lot of public health departments are struggling with what do we do with this information and how do we help these newborn nurseries that we're not in do it. Another group that I have not mentioned and I really should have is the nurse midwives too, right? So not all babies are born in hospitals. In North Carolina, it's a relatively small number. I think it's like 1% or so of births are out of hospital. Is that bigger in Texas? It's about 1%, yeah. But like 1% of Texas is a lot bigger than 1% of North Carolina because everything's bigger here. So I have a teenage son, and he was like betting me about whether or not I could put into my talk that everything is bigger in Texas. So you can all report to him that I managed to do it. So, there's issues in the in terms of screening and short-term follow-up that laboratories face. So how do you maximize laboratory test accuracy in this trade-off between sensitivity and specificity? So when you think about specificity, you really think about false positives. Sensitivity, you can think about picking up the cases that are out there. And if you decrease the number of false positives, you also end up, I mean, it's just math, you're going to miss some cases. And so figuring out the balance between those and what kind of cases you're picking up and what kind of cases you're missing is difficult, because we're talking about rare conditions. Even if you have a test that's more than 99% accurate, you're still going to have a lot more false positives than true positives. Again, it's just math. Health departments face a lot of problems related to information and communication. So what goes out and to whom? What do you have these variants where you're not sure what they mean? What do you do about carrier status, right? And so sickle cell trait, right? Who do you tell and when, and how does that get used? And then something that I think is really going to become an issue that we're all going to face, both those of us who are clinicians and those of us who live in the public health world, is this issue of late onset disease. How do you deliver that information to parents? You know, your child may have this devastating illness, but it might not be for another 25 years. And I don't know what the answer is, and I don't understand how. I don't know the best way to deliver this information or how we train people about this. Again, because it sounds like there are a lot of clinicians here, I don't want to spend too much time on the public health side of things, other than to say there are these huge issues around state boundaries as well. So if you start screening for rare metabolic disorders, there may not be a specialist in your state, and you may have to send someone across a border. Well, Medicaid doesn't like to pay for things across borders. Long-term follow-up, again, I could talk for a long time about the availability of medical food. So if you have PKU and you're an adult, by and large, you're going to be responsible for paying for that metabolic food yourself. Metabolic food is really expensive. We know that there's a benefit for individuals with metabolic disorders to stay on these metabolic foods for their whole life. And yet, because these metabolic foods are expensive, there are a lot of people who go off their metabolic diet and then develop health problems, right? So whose responsibility is it to provide these medical foods? If we think of newborn screening as a process, right, is there an obligation to provide therapy over the life of the child? What about, we talked before about some of these rare metabolic disorders. Some of them, the treatment is an infusion of an enzyme replacement therapy that you had to have over your life. So it's not curative, but it treats you. But these enzyme replacement therapies are among the most expensive medications out there, right? Who's responsible for paying for this stuff, right? And then there's all sorts of problems, even for things that aren't expensive, about adherence and access. So one of the things I have been thinking a lot about recently is hydroxyurea for adolescents and young adults with sickle cell disease. There are, let's see, I'm going to make sure I don't run over my time here, but there are all sorts of issues that are outside of newborn screening that's impacting on this now. So carrier screening, I have a logo from a company that offers carrier screening to pregnant moms for their genetic conditions that they might carry. And then there's also, these privacy concerns. I have a picture of a baby there with help the government has my DNA onesie, which I think might have come from Texas. Did that come from, was that? Okay. I'd use that picture a lot. So just for the fun of it, the other night I went to Amazon.com and I put in DNA tests just to kind of see where things were. And there are actually, of course, now I can't read the number. Who can read the number? I can't remember how many things. Oh, maybe it got clipped out. Whatever it was, there were like a gazillion things in the search, including home DNA tests, both for yourself and if you want to find out what breed dog you have, you can do that too. So, even though 23andMe is not offering, like the whole exome sequencing to those people that can pony up for it, there are many, many genetic tests out there. And for those of you who are clinicians, people are going to be asking you about it. And I don't know if anybody's come to you with like the big printout of stuff and asking you what all these, A, T, C's, and G's mean. And so I think it's incumbent on us, sort of tied to newborn screening, to think about issues of genetic literacy. And I would argue that the state of genetic literacy is low. I'm going to sort of short-circuit this slide a little bit because I want to at least have some time for questions. But who's responsible for raising genetic literacy? Because I think that a lot of the things that we talked about are going to become matters of public debate, and I'm just not certain that we're all on the same page as we go in and talk about this stuff. So I want to go back to newborn screening just for a minute. So again, it's one of the most successful public health programs. I think all of us who care for children one way or another should be proud of it and be invested in it. It's a system and not a test. It relies on dedicated professionals in public health. I really consider people who work in public health to be heroes. They do a huge amount of work for not a lot of money. It often goes unsung, and the amount of pressure that they are in is incredible. There's an increasing demand for comprehensive services following any of these diagnoses with limited resources. Again, this whole issue of limited resources is not a new thing, but I think it's going to become more and more pressing, especially as conditions come down the pike where the therapy is quite expensive. And there's all sorts of disruption by technology. And so we don't have much time to talk about it now, but I think that in the future there's going to be more and more point of care testing, including point of care genetic testing, sort of laboratories on the chips. So, I don't know where things are going to go in the future, and I know that others are going to be talking about it. I will say that prediction is very difficult, especially if it's about the future, and the future isn't what it used to be. Again, I talked about increasing use of point-of-care tests, DNA tests, growing challenges related to shortage of specialists, access to care, and all these unknown variants. But again, newborn screening programs and public health are going to continue to play a central role in figuring out how all this stuff is going to work. And so I would encourage, especially those of you who are in primary care who don't know their public health officials well, now is the time, and this is the area to do it around. So I guess I'll open things up for questions that you can't. So we now like to open the floor to shorter speeches disguised as questions. I go to a lot of meetings like that. So thank you very much for your time. Anybody have any questions now, or I'll be hanging out for a bit, or what's on the agenda next? I should know.
Yeah, you've got time for questions. Just turning on the mic.
Anybody disagree with me?
Yes, I did turn on the mic. Here it is. Well, the mic isn't on, but any questions?
Yeah.
How many states are currently passing as a
How many states have mandatory newborn screening? So, mandatory is like one of those questions. It's like hard to know exactly what that means. So, first of all states operate newborn screening programs. The individual operation of them is variable. Some states, and again, I can't tell you in terms of the state level operation. Maybe Dr. Friedenberg can talk a little bit about this, but some states operate as have these sort of hidden opt-out things, although it's hard for parents to do. I think it's fair to say, though, there are 4 million babies born in the United States each year, and pretty much all of them get newborn screening done. The other, actually, I thought you were going to go in a different direction, too, in terms of how many states have a mandate to follow the RUSP, that recommended uniform screening panel, and there's no state that I'm aware of that has a specific requirement that they follow things that are on the RUSP. But I think for all intents and purposes, most children are getting newborn screening. Anything else? Okay, well, I'll be around for a little bit if people want to talk too. Oh, is there another?
I heard that some states are offering more testing than what we in Texas are doing, like New York and Florida.
Yeah, so New York is, yeah, I can repeat. So are some states offering more screening tests than they are in Texas, like New York and Florida? It's interesting. I don't know what Florida offers, and it's one of these things where it's like hard to keep track of on a day-to-day basis. If you go to the New Steps website, they'll list out all the things that are screening. So New York historically has been sort of on the cutting edge, the bleeding edge of newborn screening, has implemented screening tests for the lysosomal storage disorders like Krabbe disease and Pompe disease. Again, Krabbe disease was looked at by the Secretary's Advisory Committee and not recommended for newborn screening. And they're doing it sort of under the guise of a pilot study to figure out whether or not there's a net benefit to the screening. Another state that goes beyond what most states do is Missouri. And they screen for the lysosomal storage disorders. Indiana has a requirement on the books to screen for lysosomal storage disorders, but I don't think that they've done it yet. And the same thing with New Mexico. I can't think of, I'm sure there's probably other states. But basically, I like to think of individual states can choose to do whatever they want, and they are sort of, that's where the, new knowledge sort of bubbles up from. So the secretary never says, well, you can't screen for that and you can't screen for that. I mean, and states can do whatever they want, but in terms of the recommended uniform screening panel setting a floor. And so it happens a lot that states screen for things beyond what's recommended. California, actually, there's another example. They screen for hemoglobin H disease, which, again, was not added to the uniform screening panel. So there's still a lot of variation from state to state, which is, from my perspective, it's okay, and it's probably a good thing, as long as all states are screening for those things that we know are beneficial, and as long as those states that go beyond what's in the recommended uniform screening panel are collecting data in a way that other states can learn from them. Does that answer your question?
Yes.
That's probably a longer answer than you wanted.
The other question that I have was the last slide that you were talking about the maternal screening genetic testing for the mother when they're pregnant.
There you go.
The carrier screening. So they're doing that, on the mother when they're pregnant. Are there any centers here in the Texas area that's doing that, like Children's Hospital here?
So I'm going to tease apart two things. So the question was about, are there any other programs in Texas that are offering carrier screening? So, this is a private company that you can, somehow or another work with to get your blood into them to screen yourself, if you're the pregnant mom, for a bunch of different conditions. And that's really something that falls outside of the public health domain. And, there are a lot of very sensitive issues that would come up related to carrier screening for a pregnant mom, including, what you do if you identify a genetic condition in the fetus, which is, again, I don't want to, believe me, it's like the last argument that I want to get into it. So that's something that really occurs outside of newborn screening. The one place, though, where screening for carriers really comes into place now is around sickle cell trait. And part of this comes from a settlement that the NCAA had because of some athletes who had sickle cell trait who died after practice in heat-related due to heat-related illnesses. And the idea is that you want to identify those children who have sickle cell trait as adolescents so that you can give them extra attention so they don't become so dehydrated and potentially die. There are a lot of people who think that's a really bad idea. And the reason is that you should never be putting any individual, regardless of whether or not they have sickle cell trait, under such pressure where you might die from heat exhaustion, right? It's just, and then the other concern is that athletes who have sickle cell trait, who may not ever have any problems related to sickle cell trait, are suddenly then treated differently. So for a lot of football players or basketball players and that kind of thing, they don't want to be singled out and discriminated against in terms of being able to play on the field because they happen to have sickle cell trait, which is really common. What's the numbers? One in something really high is the incidence of sickle cell trait. How do you like that for science? One in something really high. So, but this is going to become an issue with newborn screening because I know a lot of people are calling who are, in college trying to find out what their sickle cell trait status is, and I'm not sure, how that's going to be retrieved given the data systems that were in place back when that screening was done, 18 years ago.
Thank you.
And we'll talk a little more about how Texas handles those issues, I guess, the next talk.
Yeah. Oh.
Before I let you get away.
Before I,
One thing that we did not announce is that all the slides are on your thumb drive, so you should have a copy of all the slides for this days. And then before we let you get away, we do have a thank you.
a
for
brand new car.
A brand new car?
Yeah.
Yeah, for your time
Okay,
here
maybe
with us.
it's not a brand new car. I spoke too soon.
Too small for a car.
Okay.
Okay, let me make certain this is
Oh,
yours.
that's lovely.
Yes. And this is just a memento as a thank you for your visit with
This
us.
is really kind, and again, I really appreciate being able to come. Oh, and you've got the bag that
To
matches.
put it in the back.
All right.
Of course. All right, we're on a break for the next 15 minutes or so, and then come on back and please visit our exhibitors out front.